October in the north of Sweden, which is very hospitable and warm at that time of year, I've been told. But if you've seen this competition and liked it, then we've got your names in a very Swiss tombola here to pick out. So we're going to ask Dr. Hubner, Aurelia, where are you? To come. Can I get you to pick out the winner for the Disruptive CC, representing German EMS, but much thinner than the patients.
Luckily not a paramedic anymore.
So the winner is?
It's N-O-E.
Congratulations. So if you see the conference team at the back, they will sort you out at the end. Now, so you heard Tom Woodcock's excellent talk about fluids and fluid physiology, and that comes, as just a little overview of his fantastic book, which is some 280 pages. And I haven't looked up on Amazon yet because it's not yet released as to how much it is, but you all know how much medical textbooks cost, and I think this will be an invaluable resource. And unlike a lot of other textbooks, we have really, really up to date. So he's got one book to give away to someone lucky in this conference to get it. And so trying to think about how do we pick who this book would be most useful for. And I think the best way to do it is to find out who the best big sicker is. So if you'd like to all stand up, I'm going to ask you some questions. And if you didn't do these things, I'm going to get you to, stand up. Everyone stand up. So, okay. So if you weren't here for all 3 days of the conference, sit down. If you didn't go to the ultrasound workshop, sit down. If you didn't go to the airway workshop, sit down. If you didn't look at the ECMO, then sit down. If you didn't have a go at the David Knott Foundation triage and the overseas environment medicine, then sit down. We're getting down to the real big sickers here, aren't we? Okay, so if you didn't go to Ross's excellent presentation talks, then sit down. Oh, okay. So, if you didn't ski or snowboard, then sit down. Oh. If you're not on Twitter, sit down. I think we have a winner. The last thing, I was down to my last tiebreaker, which was if you don't follow me, sit down. But I know you do, so well done. If you contact the guys at the back, they'll arrange for the book to be sent out to you. And one last thing, is Katrin here? Is Katrin our ski guide here? Where is she? It's so hard to spot a tall blonde person in the room like this. Is she here or? Oh, okay, don't worry, we'll give it to her later then. Right, so moving on to the last set of lectures before an excellent workshop that we're going to do at Zermatt later on. We've got a paramedic from the Colorado in the US. I sort of asked him if I should make some Trump jokes or not. He didn't declare which side he fell on. So I'm going to skip that.
No, you're good. You're good.
Yeah, I've been to Colorado and it looked very, very dusty and sort of lots of beautiful ravines and stuff. But I didn't realize you had cities and stuff. But I'm sure we're going to hear about that. So you've been in EMS for 10 years, I believe, and you're ground-based EMS, which means you do exactly the same medicine as us, but you don't arrive in this shinier machine. So, clearly that's inferior.
Right. Much more efficient.
So, what are you going to talk to us about? So, there's been a lot of stuff, a few things that were referenced earlier in some other speakers' lectures about intubations, and I think there was that terrible, terrible study that I think denigrated paramedic intubation a long time ago back in the US, which you'll probably all have read, where it's a poor training. But then you've got brilliant systems like the MICA system in Melbourne, which go to show that you can deliver safe, highly complex interventions regardless of your background and specialty. And I think Andrew's going to be talking to us about, as a London HEMS doctor, one of my favourite things, ketamine. Welcome.
Thank you so much. So it's a pleasure to be here. I'm going to talk to you guys today about ketamine-only intubation. And so the name I use for this procedure, or the description I use, is ketamine-only breathing intubation. And I like that name for it because it's descriptive, but it's also easy, and we can make a fun acronym out of it. So you have to have a fun acronym for all of your airway techniques, right? You have to have something easy and something that will kind of flow off the tongue. So it's interesting, in kind of researching this topic over the past few years, I've really discovered there's two distinct groups of people and their views on the procedure of ketamine-only intubation. There's a group of people that really like the procedure, they use it regularly, or they want to use it regularly, they see the potential benefits. And there's a group of people who are more skeptical because there's not a ton of evidence on outcomes, there are some potential adverse events. And, I don't know, did that just cut out? No, you're good. Okay. There are potential adverse events, so we have to make sure that we're doing it safely. But I think the people that... It sounds like it's cutting in and out. Okay. How's that? No? No working? No working again? No. Yeah. I have mic problems every time I speak at a conference. It's pretty much inevitable. How's that? Is that working better? We'll see if this... Oh, there we go. How's that? Alright, how's that? That better? Okay, cool. Let's go with it. Okay, so... Jesus. You want me just to use the hand mic? Nice. How's that? Alright, I'll hold it real close. All right, now it sounds like I'm yelling, but that'll work. So there's a group of people that really like this procedure, and they see the benefits of using breathing techniques in our sick patients and keeping our patients breathing during the intubation. So we know that ketamine has that distinct advantage. And what I want to talk to you guys today about is when I think we can consider using ketamine-only breathing intubation and other breathing techniques such as awake intubation, what the potential risks are, how we can mitigate those, and how we can respond to them as well. So the first thing I want to talk about is RSI. So we need to understand why we do RSI and kind of what the benefits are from RSI. It's a foundational procedure, right? That's the airway technique we go to in many of our critically ill patients. RSI has a strong evidence base, and we know that it facilitates success in a lot of these patients. RSI gives us an optimal view of the airway. We have a relaxed upper airway. We're able to more adequately displace airway tissue. And we have a patient that's not breathing, so their vocal cords are still. It's easier to pass our tube. We're also less likely to get Mount Vesuvius, right? We're not going to get spontaneous emesis or vomiting during an RSI. We can obviously always have passive regurgitation, but we're not going to get spontaneous vomiting, which means fewer episodes of aspiration. So these benefits really make RSI a go-to procedure for many of us for most of our critical airways. But of course, we're always balancing those benefits against potential risks of RSI. We're always adequately preparing our patients, resuscitating our patients so that we can mitigate the risks of RSI maximally. So we know sedation, depending on which agent you use and how you dose it, can contribute to hemodynamic compromise, and that can be a problem in some of our patients. We also know that paralysis can potentially impact hemodynamics, but it's also by intention going to cause apnea, which is often the biggest problem that we're trying to mitigate when we're doing an RSI. So apnea, we know apnea okay, so we know apnea is going to potentially contribute. Okay, so we know apnea is going to potentially contribute to faster desaturation and worse oxygenation during our procedure. But apnea also has significant effects on hemodynamics, which oh boy. All right. Third time's the charm. Good? Good? So we know, oh my God, every single one. Just try the first one again, right?
Yeah, we could. Try that one out.
Change the battery. All right. Can you guys hear me through this one? Okay, let's try that again. We'll get this done at some point, don't worry. At least you're not waiting for cheese this time, right? So we know apnea not only can contribute to desaturation and oxygenation problems, but it's also going to potentially contribute to hemodynamic problems as well, because we know the primary driver of preload to the right side of the heart is a negative pressure ventilatory state. So we're generating negative pressure in the chest, which is drawing preload back to the right side of the heart. So if we take our patient that's very compromised and make them apneic, that can cause further hemodynamic deterioration. And then on top of making them apneic, we're going to have to generate positive pressure when we ventilate these patients, either during RSI or afterwards when we put them on the ventilator or BVM ventilation. So generating positive pressure in the chest is obviously going to further decrease venous return to the heart and further contribute to hemodynamic problems. So in many patients, these things are not that big a deal, right? We can address these issues of RSI, and many patients will tolerate them just fine without much effort. But we certainly have to consider them in our sickest patients. And then on the other end of the spectrum, we have awake topicalized intubation. So I view awake intubation as kind of the pinnacle of airway management in a really critically ill patient, because it's going to give us the significant benefits of a spontaneously maintained airway and spontaneous breathing. So we're going to have less desaturation, and we're going to potentially have fewer hemodynamic complications because we're allowing that negative pressure ventilation to continue. So these benefits really allow awake intubation to be beneficial in many different types of difficulty. But of course, like anything, awake intubation has its own problems, and it's mostly because it's more procedurally complex. So it's not always going to be available, whether that's because you don't have a provider that can perform it, or because you don't have the correct equipment available at the time of the intubation. So it's not always going to be available, and even if you do have the correct providers and the correct equipment, you need a patient that's going to participate and that's going to be more appropriate. More critically ill patients may not tolerate this procedure as well. So this is where I think ketamine-only breathing intubation comes into play. So we know that this procedure is trying to get benefits from awake intubation and from rapid sequence intubation. We're trying to keep our patients breathing and maintaining a spontaneous airway, which is coming from the awake side, but we're also trying to be able to use techniques that we use on a regular basis when we're doing RSI. So we're trying to use standard airway techniques that are more readily available to everyone. So what is ketamine-only intubation? So we're using dissociative dose ketamine. So that dose is going to be very different depending on your patient's hemodynamic status, right? So we know higher doses of ketamine in patients who are in shock can still potentiate hypotension. So in those patients, I like to do incremental dosing, so small doses of ketamine until we get the patient dissociated adequately. And then higher doses for patients that can tolerate it. And we can also add topicalization to this as we would in an awake intubation. If you have time and you have the proper equipment, if you can topicalize prior to your intubation or during the intubation ahead of your laryngoscope, that can potentially make your airway less reactive and have a patient that's going to tolerate the procedure better. And we can use standard intubation techniques. So you can use whatever laryngoscope or laryngoscopy method is most comfortable for you and most appropriate for the patient. You don't have to go using an intubating scope on every single patient you do this procedure on. And then the crux of it is we want the patient to maintain spontaneous breathing, right? Because no matter what kind of difficulty we're trying to overcome, a spontaneously breathing patient is likely to have fewer adverse events during the intubation. So this sounds really great, right? Like if we can keep our patient breathing throughout our intubation reliably. We can use standard intubation techniques. It sounds like an awesome procedure, and I think we would use it on pretty much every patient if it would really be this kind of situation, right? If there were no significant downsides to this, it would be something we use on every patient. But of course we know that there are risks to this procedure, right? There are significant risks to using ketamine in airway management. And the main ones we think about are apnea, laryngospasm, and jaw rigidity. So these are the ones that really come to mind when we talk about using ketamine as a sole agent. So I want to talk now about how we can mitigate some of these risks and how we can potentially respond to them and hopefully prevent them from occurring. So the first thing, I think despite this being a ketamine only, you have to have a paralytic available, right? Because we know a lot of these adverse events, is this still, yeah, it's working, okay. We know a lot of these adverse events can be solved by giving a paralytic, or will be resolved if we give our paralytic. So I think having a high dose of succinylcholine or rocuronium ready to go when you do this procedure is essential to mitigate adverse events as they arise. On the same mindset, we have to have surgical airway readiness, and I think this is fairly common for any advanced airway technique we're doing in critically ill patients today, but especially when we're using ketamine only, we have potential events that could be more likely to necessitate surgical intervention. So having surgical airway readiness is also essential. But I think the thing that's going to benefit us most is to give our ketamine extremely slowly. So slow doses of ketamine are probably less likely to cause apnea and laryngospasm specifically. We're usually less likely to see those adverse events if we give our IV ketamine much more slowly. So I like to draw this up into 10 mLs of normal saline and give it very slowly as a bolus over at least 1 minute, if not up to 2 minutes, depending on how much time you have. And then we also have to consider that this is not going to be a typical intubation. And there's many people in the room that have experience doing breathing intubations, but there's probably people that usually do RSI and intubate patients who are paralyzed. So we're going to have an upper airway that is not fully relaxed. We're going to have upper airway muscles that still have some tone. So it may be more difficult to get an adequate view of the glottis. And we're also going to have a larynx and vocal cords that are moving, right, which can potentially make our intubation difficult, make our tube passage more difficult. And there's a few different ways we can approach this intubation and how we want to decide on our technique that we're going to use. I think using a Mac blade with video capability plus a bougie, and I'm a little biased because I'm a big bougie fan, but if we use a direct laryngoscope with video capability and a bougie, that's going to give us a benefit of VL, and the bougie is going to make it easier to enter the glottis through moving vocal cords. We can also use hyperangulated video laryngoscopy because we have more upper airway tone, so it may make sense to use a device that can help us look around the corner and deliver that tube around a more stiff jaw. And then of course you can always use a flexible intubating scope for these patients as well, more of an awake style technique. That's also always an option if the patient's appropriate. So now I want to talk about responding to these adverse events. So let's say we've done everything we can to mitigate, but we still see some of these adverse events. The first one to mention is apnea. So and apnea does not have to be a huge deal here, but you do obviously lose the benefit of a breathing intubation. I think if we're giving our ketamine slowly and we're selecting our patients properly, you're not going to see this too much, but you will see it. You may need to ventilate your patient if they are desaturating, but you can also potentially just continue with your intubation, knowing that you've lost the benefit of a breathing technique and kind of falling back on more of an RSI. And then some people may say, oh, the patient's already apneic, I might as well give my paralytic and get the benefits of paralysis. So that's also an option in response to apnea. Now, jaw rigidity, masseter muscle rigidity is another one. This is a really interesting one because most of the cases of this that I've heard seem to be related to under-dissociation. So the patient has not gotten enough ketamine. So they still have spontaneous upper airway muscle tone, and they might actually be resisting your intubation attempts, and that's what's causing this jaw rigidity. So sometimes the antidote for this is just more ketamine. Get your patient fully dissociated so that you can then go ahead and intubate once their jaw is relaxed. Now, you're never going to have a completely flaccid jaw under ketamine like you would with paralysis, but you should have kind of neutral tone. If that doesn't work, you may have to move on to paralysis. That would be your next step if you're trying to take an oral approach. If you are planning on taking a nasal approach with an intubating scope from the beginning, maybe you can continue doing that as long as your patient's still spontaneously breathing. But I do think many of these cases are going to resolve with ensuring that your patient's fully dissociated. Now, when we talk about laryngospasm, this is one that people really fear with ketamine. Most of these incidences of laryngospasm under ketamine are fairly transient. So usually they're going to resolve within 30 seconds to 45 seconds, it seems. But that's not always the case. So the initial response to laryngospasm that's not resolving is gentle positive pressure along with the Larson's maneuver, which is pressure bilaterally in the laryngospasm notch. Many of you are probably familiar with this procedure. And it's been shown to potentially help resolve laryngospasm. So if we put a little bit of pressure through a BVM mask or an anesthesia circuit, try to get that glottis to relax, combined with Larson's maneuver, that may be beneficial. If that doesn't work, the next step is typically paralysis. Paralysis should relax laryngospasm and allow you to pass your tube. If paralysis is not quick enough, or it's not something that is a good option at the time, obviously the next step here is going to be to move to a surgical airway. But typically these basic methods in paralysis are going to be enough to resolve your laryngospasm. So now I want to talk about when to consider doing ketamine-only intubation and what patients can benefit from a breathing technique. And I think, in general, I think of these patients as, if I paralyze this patient, they're going to die, or it's going to cause significant compromise, despite everything I've done to resuscitate the patient prior to intubation. And this is also assuming that awake intubation is not an option or not feasible in your patient. And these patients fall into two general categories, anatomic and physiologic difficulty. We've all heard of this. We've heard of the HOP killers. These patients who are anatomically difficult are those who you think, I'm not sure if I can intubate this patient, so I want more time to mess with the airway and find a technique that works. Or you want to try to take a nasal approach with a scope to try and keep the patient breathing. This can be patients with baseline airway difficulty, so obesity, small mouth opening, short neck, or it can be patients who have pathologic upper airway disease such as Ludwig's angina and angioedema and diseases like that, where you want to keep your patient breathing during the intubation. Many of these patients are much better off being done completely awake, but that's obviously not always an option. And then our physiologically difficult patients, I think these ones are underappreciated, probably not so much by this group, but in general I think patients that are more likely to deteriorate with paralysis are missed. They fall into three general categories. And the first is going to be patients with severe oxygenation deficit. So this is a patient who, despite adequate pre-oxygenation, despite any efforts you've made to maximize oxygenation, you're still very concerned that they're going to desaturate during your intubation or while they're paralyzed. So you want to keep your patient breathing so that you can maximize oxygenation during your intubation attempt. Then we have patients who have severe perfusion deficits. So these are the ones that you've hemodynamically resuscitated maximally, but you're still very concerned. It's a patient that still has a shock index of over 1, despite everything you've tried prior to your intubation. We know that these patients can benefit from having that negative pressure breathing maintained throughout their intubation, so they're less likely to deteriorate when you make them apneic and then give them positive pressure. And interestingly, if you use a breathing technique, you can potentially keep your patient spontaneously breathing after the intubation as well on your ventilator. You can hopefully maintain some spontaneous effort on your ventilator to maintain that negative pressure breathing after your intubation. And the last group is patients with severe metabolic acidosis that have respiratory compensation. Now these patients may have minute volumes of 20 to 30 liters a minute, and we know that making them apneic is not ideal, and it may cause a significant drop in pH. So we know that ketamine is probably not going to maintain a minute volume of 20 to 30 liters per minute. You're not likely to see that huge of a minute volume maintained during an intubation. However, the decision really is, do I want to try to maintain some minute volume, or do I want to have none if I have to do an RSI? And obviously we try to avoid intubating these patients if we can, because patients can compensate much better than we can on a ventilator. But sometimes your hand is forced. So keeping them breathing may be a way to maintain some of that minute volume and some of that compensation. So now I want to talk about how I kind of think about getting to COBE. How do I incorporate this into my practice? How do I get there from other procedures that I'm using? So we can get there from RSI, right? And I think this is going to be most commonly because our go-to in many of these airways is RSI. So let's say we have a patient who we're going to do a rapid sequence intubation on. They're hemodynamically compromised. We have maximally resuscitated them. Their shock index is still 1.2. We're still very concerned about their hemodynamic status. So what you can do is say, I'm going to attempt to intubate just under ketamine dissociation and see how they maintain their respirations during that dissociation. If I need to fall back on my paralytic, I can. But if they are maintaining spontaneous respiration, I can continue intubation just under ketamine. And then we can get there from awake intubation. This is also fairly common. I think patients that may not be tolerating topicalization or not tolerating having their airway manipulated while they're awake, we can say, all right, I'm going to push them to dissociation and do the intubation that way with them spontaneously breathing. And then I think we can also get there from delayed sequence intubation, which is probably one of the more interesting routes. So I'm sure most people are familiar with DSI. DSI, we're using ketamine to facilitate pre-oxygenation in a patient who doesn't otherwise tolerate it. So we dissociate our patient with ketamine, we pre-oxygenate them, and we typically give our paralytic afterwards and do the intubation. Let's say we have a patient who is hypoxemic, we're pre-oxygenating them under ketamine dissociation, and they look really good. They're still breathing, they're maintaining their airway. We say, I'm still concerned that they're going to desaturate when I paralyze them, so I'm going to keep them in ketamine dissociation and attempt to intubate them under those conditions. And again, we can always fall back on the paralytic if we're not getting the views we need or the patient doesn't do as well as we anticipate. But I think that's one way that you have that kind of period where the patient's already dissociated so you can assess them and see if you think they're going to tolerate the procedure while you're doing that pre-oxygenation. And the last main point I want to make is that implementing this technique or any airway technique that's a little bit different from what we usually do requires simulation and practice. We have to go to the sim lab with you and your team, make sure everyone's on the same page, has run through these scenarios, has run through responding to these adverse events, and so that we know how this should go and make it as safe as possible for our patients. So that's how I think ketamine-only breathing intubation falls into our current airway paradigm. So in summary, ketamine-only breathing intubation, we're using dissociative dose ketamine, plus or minus topicalization, and we can use typical intubation techniques, and we're trying to facilitate a spontaneously breathing patient during our intubation. We can use this in patients that are anatomically or physiologically difficult. And our main risks that we think about are apnea, laryngospasm, and trismus. We can make these things less of an issue by giving our ketamine very slowly and having surgical airway and paralytic readiness whenever we're doing this. We can use standard intubation techniques, whatever's most comfortable for you and what's most appropriate for your patient. And as always, practice, training, and simulation are essential to make sure that this procedure is as safe as possible for our patients. Thank you so much for your time.
Hello. Ben, thank you so much. That's an excellent talk and a really good topic. And I'm going to have to hit you up later at the bar because I'm going off to Africa in a couple of weeks' time, where I'll be doing some ketamine-only intubations, and I have very little experience of that. So I'll be chatting to you later.
All right, great.
But one question that I was worried about what I'll be doing in a few weeks is the salivation that you
Yes.
get. So what do you do to mitigate that?
So you can use agents like glycopyrrolate or potentially atropine to mitigate that if you're concerned. If you have more time, I think that's a good issue. By the time, if this procedure is progressing as quickly as a typical airway would, your hypersalivation is going to be somewhat delayed, at least in my experience. So you might have time to get by it. I've always been able to manage it with suctioning, and I've used atropine in the past if it's been really bad. But I think those two agents are a good option.
Oh, that's brilliant, thank you.
Yeah.
Questions from the audience? Oh, by the way, whilst I walk down here, so there are mountains in Colorado. I forgot that part.
That's Colorado, yep. Not quite as dramatic as here, but they're pretty nice.
Thanks for your presentation.
Of course.
Do you have any plans of doing a trial, publishing something, in a bit mirroring what Scott Weingart did with the delayed sequence intubation?
Sure. So at this point, we do have some efforts to put together a case series on this, but there's very little data. I don't have resources right now to run a full trial, or at least the patient volume. If you're performing this procedure, I certainly encourage you to publish the cases, because we do need more data. We want to know if this is improving patient outcomes, so the more that we can do. But at this point, I don't personally have any plans, but I would certainly like to see it.
Yeah, can you comment on, there's something sort of the mythical contraindications. They talk about the emergence phenomena.
Sure.
And there are people who, under subdissociative doses, will have agitation and it's not quite as smooth as you'd like it. You want to comment on how you would handle that?
Sure. So with this procedure, our goal is full dissociation. So we want to make sure our patient has progressed kind of past that subdissociative or partial dissociative phase and they're going to be fully dissociated. So if I see that in a patient I'm preparing for this, I'm just going to typically give more ketamine to make sure they're pushed through that partial dissociative phase and get them fully dissociated. That being said, after they're intubated and we're giving additional sedative agents, either propofol, midazolam typically, those agents are really good at mitigating psychological effects. So if this is a patient you're going to be awakening soon, like if it was for an anesthetic procedure or an operating room procedure, using those other agents can also help mitigate that partial dissociation, so your more conventional sedatives.
Any other questions? Well, thank you so much. It was really insightful. Oh, sorry. Yes.
I have a question regarding how to get started with COBE, with the
Sure.
Spontaneous ventilation ketamine. The thing is, when we simulate RSI in simulation center, it's easy.
Sure.
But then you have somebody who has never trained spontaneous ventilation in intubation with ketamine. So do you have any advice how you can get started with this, whether to go to theater and get some experience with ketamine and spontaneous ventilation patient, because the conditions are very, very different. The limitations you mentioned are quite serious sometimes.
Certainly, yeah. So the adverse events I mentioned do seem to be fairly uncommon, especially if we're using those techniques to mitigate them. But as far as implementing it into your practice, if you do have anyone in your facility that's doing any kind of breathing technique, that's certainly going to be helpful. In theater, you're more likely to see probably breathing techniques done for preoperative induction of anesthesia, so that may be helpful to kind of get used to it. Otherwise, I think reading what literature there is out there and kind of getting a baseline understanding of what the procedure is, and then develop your own kind of protocol for it and take that into the sim lab. That's the place to start. Just kind of run through the motions. And then when you start to see patients that are appropriate, just obviously be very diligent with your preparation. I don't know that there's a better way to implement it.
Yep. I'll make this the last question.
Just a short question about severe hypoxic patients.
Yes.
Would you go for ketamine only or RSI with ventilations? Because I would imagine that you would get the tube down faster if you paralyze the patient.
Yeah, I mean, that's obviously kind of the risk-benefit we're always making. That's the risk-benefit decision we're always making. But do we want to make our patient apneic? Obviously, if we're going to have to ventilate during the apneic period, we do potentially increase the risk of aspiration, although the literature is not clear on that. But in patients that are not fasted, have been eating, we don't know what the risk of aspiration is if we're doing ventilation during that peri-intubation period. So I think it depends on how easy do I think it's going to be to intubate this patient. We're not great at predicting that, but if you think it's going to be a really terrible airway, maybe ketamine only is not the best idea, just because depending on what technique you have available, you might not be able to intubate as quickly as you'd like. But also, you may end up having more time to get that tube delivered if you can keep your patient breathing. So that may give you more time to manipulate the airway and get the tube secured, since you're able to maintain oxygenation better during that intubation.
Brilliant. Thank you so much. So Final talk for the day is really going to take us to another level and take us literally out of this world. So Matthieu Komorowski is a lecturer at Imperial College in London and a consultant in intensive care at Charing Cross, which is my alma mater. And he's previously held positions with the European Space Agency and NASA. And he's going to talk to us about extreme resuscitation.
All right. This is actually a talk I've been wanting to prepare and give for years and years. So really, I'm really grateful for the opportunity to having been given that spot. So I'm gonna leave that here for a second. On a long enough timeline, the survival rate for everyone drops to 0. Okay, so this talk is gonna be about how much we're willing to do to push that line up. It's a talk about innovation, medical innovation. It's a talk about what makes a pioneer, what makes a criminal. It's also a talk about the blurry boundaries between science and fiction. So we're going to start gently with single organ failure, and then, if you want, we'll go to some very dark places. Starting with Mark Jokes. He was a nephrologist. He was the first to publish the successful use of a dialysis machine. So this was in 1948. He published a case series of 12 patients, 10 of which died very quickly, but 2 of which survived, and this was much better than what they had been able to do before that. He explains in that publication that he imported that machine from a Dutchman called Willem Kolff, and very quickly they both were recognized for their great contribution to the field of medicine, and in fact there's over 1 million patients nowadays that are on chronic dialysis. Second chap is Philip Drinker. He was an engineer, and he was also working for the newly formed Harvard School of Public Health in the 20s and 30s in Boston. And his contribution was the invention and the first successful use of the iron lung machine. And obviously that had a huge impact with all the early polio epidemics. And the first successful use was in October of 1928, and you see that picture here with that little 8-year-old little girl. And we've all seen those pictures of those wards, very impressive, full of iron lungs, and drastically improving outcomes, and to some extent laying the foundation for intensive care medicine. You may be surprised, but there are I don't know if the sound is going. We don't really need it for that one, but we'll need it for future videos. I don't know. Can we check the sound's working? Yeah. So the point of that video is that some patients are still today, as we speak, on iron lung machines. Right. This is one of these patients in the U.S. There's no sound. I don't know if that's okay, but can we check? Thank you. Wonderful. Next chap, Forrest Dodrell. So in the 50s, he was a surgeon. Sorry, I forgot where it was. In the U.S., Detroit, of course, Detroit, because he was the inventor, along with General Motors, of the first cardiopulmonary bypass machine, and the first successful use of that machine for open heart surgery. In 1952. The patient went on bypass for 50 minutes for repairing his mitral valve, and again he achieved fame. Was recognized as a pioneer in heart surgery. Okay, well, do you wanna pause? Yeah, let's try. It does matter for the later videos. That's all right. It's the last speech, so we have plenty of time.
There might not be cheese, but
There are helicopters. Yeah. So where we tend to see, I did a lot of reading, obviously, preparing this talk. What struck me is that those early innovators, those early inventors, they were very quickly recognized for their contribution. There seemed to have been very little criticism, and things are very, very different when we look at transplantation. And that's a point I'm going to make in a few slides. But transplantation seems to have a whole different level of concern. It was failing over and over again in animal studies, and all the early attempts were failing because we hadn't mastered immunosuppression, we hadn't mastered the surgical techniques, and also I think there's also an ethical aspect around the desacralization of the body of the donor, the body of the recipient, that adds an interesting layer in terms of ethics as well. That's all right. I saw something funny this morning on my phone. Have you heard of that thing called the coronavirus? I think, yeah. You've heard of that thing called the Corona beer, yeah? So if you look on Google Trends for a Corona beer virus, I think it will make you laugh. It did make me laugh a lot. So people seem to be confusing both. And the trend for the search for Corona beer virus is absolutely exploding. Okay. But it says it's muted, no? Okay. Can we try a different laptop? Do you guys mind? I think it's important because otherwise it's making this the whole talk a little bit useless. Not for that video, but there are stories later on.
Matt, you need a couple of minutes so we can do something else in the middle. If you don't mind, sorry to interrupt your thing. Whilst we're waiting for that to happen.
No, I don't mind.
Katrin, could I possibly ask you to come up?
No, it's okay.
Katrin? So, some of you guys probably seen Katrin around with the guiding of the ski groups and stuff. I was going to do this at the end, but rather than just sit here and watch IT being twiddled around, the organisers have asked me to let you guys know that this lady has been doing a huge amount of work in the background to get all of the conference working and done, and then she's also taken the time to ski with all of us and guide us down, though she laughs at me and skis past me a lot, but I can forgive her for that. And as I said the other day, I heard that she'd been sponsored earlier in her career by a clothing company for her skiing when she was in Chamonix, and now I'd like to tell you that Hamilton Medical have decided to continue sponsoring you for your skiing, and I would like to give you this from the organiser to say thank you so much. So. And I will beat you down the slope one day.
Getting down and dirty with a Procyon loader.
I have my laptop, but it's a Surface. It's a Surface. USB stick. The USB. It's obviously it's not working. I mean, if you have another laptop, we can try this. Or I'm gonna run get the plug. Sorry. So the baboon had his blood replaced by human blood before doing that. I think I'm not sure it works that well since we haven't seen that being done in a long time. So to summarize a little bit about the single organ phase, what we're seeing is that over the years we've developed machines to replace acute failing organs, and then patients can either recover, either go into long-term organ support, or be transplanted. And this is the transition to the next phase. So Richard Lawler was the first to successfully perform a kidney transplant on this 44-year-old lady who was suffering from polycystic kidney disease in 1950. What was the reaction from the scientific community? They called this a maverick attempt, since every previous attempt had failed, since there was no immunosuppression at that time. The kidney only lived on for a few months. They said that it was of no scientific significance and of no benefit to the patient. Okay, 1950. But fast forward 2020, 70,000 kidney transplants per year are done in the world, right? Eventually he was recognized for his important contribution. Christian Barnard, I don't think he needs any introduction, but he was the first to successfully perform a heart transplant. 1967, this gentleman lived on for 18 days. Okay, what was the reaction from the medical community? What he was attempting is unnatural and impossible. Okay, obviously Christian Barnard went on to become extremely famous, dated a lot of attractive women, met the Pope, not only once but twice, 2 different popes. Try to beat that. Thinking about the future, there are today, as we speak, 120,000 people in the US waiting for organs. 24 die every day. Okay, is there anything we can do using technology, using for example genetic and bioengineering to address this question? This is what this team is proposing to do. There are different people working on this question, but what they want to do is modify embryos of pigs, injecting, so it was published in Cell, this is 3 years old, injecting stem cells into the embryo of a pig and then developing chimera, mixed animals that could potentially grow fully human organs that then you could harvest and transplant into humans. Okay. Single organ failure. Moving on to multi-organ failure. How do we deal with multi-organ failure in our practice? What we do is we connect the patient to lots of extracorporeal life support systems, and they are put in parallel. Okay. There's another concept that was proposed in this paper here, that's the reference on the right. The idea of a total extracorporeal organ support system where you would put the machines in series on a single extracorporeal circuit. And we start to see a pattern emerging here. This is something I've been very puzzled with since I don't know, as long as I can remember, medical school maybe. How much of organs can we supply, can we replace? Could we remove body parts that are infected, ischemic, cancerous, right? We do it all the time, but could we go further? How much could we chop off? See, this particular individual has already lost its limbs, but could we keep going? And this leads me to this phase about how do we handle irreversible multi-organ failure. I don't know if you know this news from this news story, this short story from Roald Dahl, published 1959, the story of William and Mary. If I'm gonna need YouTube for that one, so I don't think that sound is working. Could we? No, it's working on your computer, but that's it. Okay. Or maybe, what if I put my microphone next to yours? Let's try. No?
Name is Igor. It's Russian.
It's
The head has been completely severed
can you pause?
from the body. No, okay.
Okay. so the plot before we play it. I'm glad the sound's working. William died. He had cancer. Okay. A week later, Mary is summoned into the office of Dr. Landy, who's a neurosurgeon, who looked after her husband. Okay. And do you mind just starting from the start?
I don't know. It's a dog. On a plate. On a plate. Dog's head is on a plate. His name is Igor. It's Russian. The head has been completely severed from the body. Oh, God. But it is alive.
Can we dim the light?
As you can see, normal blood supply is being maintained from artificial heart. The brain is functioning. Now, as you can see, food is being offered. The dog's tongue comes out to lick it away. Wait a minute. Wait a minute. What in God? Not so fast. What in God? I put it to William. I said if it is possible for a dog's brain to remain alive, why should the experiment not be perfected upon a human being?
Oh my God! You've got William's head in there.
I put it to William. I said what I need is a guinea pig, a human guinea pig, of course. Did he agree?
He what?
Yes, he agreed.
Don't believe you. I don't believe you. William would never have agreed to anything, so he was much too
cautious. And I put it to him exactly how I would proceed. First, I would have to enlist the aid of an artificial heart. Second, I would have to step in at the right moment, just before death, and remove the brain from the skull. Because the object, you see, was to keep the brain alive.
But William is dead. How can his brain be alive?
It was rather tricky. We only had 3 minutes to complete the transfer of blood supply to the brain. That's all we had, just 3 minutes.
God, what about the pain when you started?
William asked me that question, so I agreed to give him a shot of procaine, just in case.
You gave a dead body an anesthetic?
No. At that moment, the body was not yet dead. So William insisted. Well, I won't go into the vast amount of technical problems we had to overcome, but suffice it to say that the experiment was a complete and unqualified success.
I don't understand. What is the point of just having a brain?
Because it continues to function.
All right. What is the point in just having a brain? And the answer is because it continues to function. To me, it makes little doubt that Roald Dahl was aware of this thing, this experiment from the 1940s in Russia. What these surgeons had demonstrated is that you could sever the head of a dog, connect it to a heart-lung machine, and have that head appear to be alive for several hours. And this footage is absolutely striking, of course, of animal cruelty, but also from a medical standpoint, I think it's so they're tickling the dog. Dog is connected to this machine that pumps blood into its brain. They're shining light into the dog's eyes. They're going to be stimulating him with a hammer as well, with noises, not on the dog itself, and you see the dog. It looks pretty alive, and as far as I can tell, this is real. 1940. So this has inspired, probably horrified Roald Dahl, and then inspired him to take this further and to say, oh, what if this went into the wrong hands? Would we be doing this to humans? People went even further. These are experiments conducted in the 50s and 60s by Domikov. It was a very prominent surgeon, a pioneer in transplantology, and he developed a technique to transplant the head and the upper limbs of a dog onto another dog. Okay, so he created these two-headed dogs that some of them lived for several weeks. Okay, and you see the two dogs lapping at the same time. Obviously, going from there to humans, let's try to do that jump. You probably have heard of Sergio Canavero, Italian surgeon, and he stated multiple times in the news that he was going to be the first to perform the first human head transplant. Whether you call this a head transplant or a body transplant, I leave that to you. But in 2017, 2018, there were rumors that it had been cleared to do it in China. He was working with this other prominent Chinese surgeon. Hasn't been done yet. There's actually surprisingly a fair amount of literature on this topic, including this review. The indication is for patients suffering life-threatening bodily illnesses. This paper lists the technical challenges that we'll have to overcome, and you see that most of them, we haven't solved it, unless you consider that living tetraplegic on a breathing machine for the rest of your days is success. There are also a lot of interesting papers around the legal and ethical barriers of trying to do something like this. Fascinating read. This one I highly recommend it. Let's go through a few of those issues. I'll leave that to your. I'm not going to answer those, but what about the issues of distributive justice? Is it okay to use one body for one patient when you could spread those organs to potentially save 8 people? Costs and organizational procedures. People said that you would need a team of 80 surgeons, and the cost would be between $10 and $100 million to do that. $100 million. How do bioethical and neuroethical principles apply? Can a patient consent to be killed? I think that's a fundamental question given the extremely low likelihood of success. Legal regulations of human subject research. The legal consequences for surgeons. Decapitating a live human being is not strictly speaking legal or allowed. Metaphysical and the legal identity of the recipient. Again, very, I think, very interesting questions in theory. We're going to move on to a different topic. First person to recognize that movie gets a high five right now. Who did that? High five. Alien, Ridley Scott, 1979. So this is the opening scene of the movie. You have a crew of 6 people who are in cryosleep, in hibernation, in suspended animation, and they get woken up by the ship computer. And this is a typical scene you find in science fiction movies. Those people, they seem to be having a little nap, right? And in fact, they've been asleep, so the story says, for years or decades. And you see them waking up. See, they look very peaceful, comfortable. They have very minimal monitoring and invasive equipment. Oh yeah, no, there's an electrode on the neck. Sleeping like a baby. And he's gonna wake up very gently. This is a theme that's very recurrent in science fiction, and in general highly unrealistic. You see he's looking a bit tired, but that's better than the way I look on most Sunday mornings. And then he went on to then kill aliens. That's maybe a slightly more realistic scene from Ad Astra. We see Brad Pitt inserting a percutaneous gastrostomy for feeding. And then, so you see the food going in. And then he gets connected to some electrostimulation to prevent muscle wasting. All right, but there's nothing about sedation, airway, whatever. Okay. What are the potential applications of these technologies? Okay, space travel, I think, is not a very pressing need right now. Time in trauma care, much more interesting. We'll talk about this in a second. If you can lower the metabolism so much that it doesn't really matter for a little while if your heart is beating or not, that is very valuable. Potentially all incurable disease. If you could be put to sleep and wait until the treatment comes available, why not? Well, same thing if you're waiting for an organ. We talked about the waiting lists. Military use, I'm sure there could be lots of potential uses there. mine disasters, submarine rescues, fire escape. Same thing. If you can lower your oxygen consumption very for a very long time, you could survive much longer. You could potentially fast forward to whenever you want in the future. Sleep efficiency, or could we sleep shorter, or could we sleep better? Extend our life. Capital punishment. Is it better than death penalty? This was the plot of Demolition Man, right? You remember? 93. There is actually some literature on research teams trying to solve this question. So this is an example of one of them, highly naive, if you ask me. What they want to do is put the astronaut in hypothermia and feed him using TPN. That's it. So nothing about, well, you know, being cooled down to 10 degrees is not going to be very comfortable. So what about sedation, shivering, airway management, muscle wasting, and so on. So there's much more interesting the literature around animal hibernation. The cool point here is, think about it. Hibernation is a very common feature in lots of different animals. What does that mean? It means that most likely it is induced by activating a set of genes that are shared across lots of animals, potentially including humans. So there's strong evidence that we could induce hibernation in humans. Some data from the animal world, fascinating. This is the marmot on the left. The marmot's body temperature goes to 10 degrees for weeks, sometimes during the winter. Even more insane, I couldn't believe it. The ground squirrel, body temperature goes to -2 degrees Celsius. That's not a typo. Okay, below freezing temperature. We're talking about a mammal, right? And they survive, and they do fine. Can we induce hibernation in mammals? Potentially. This is a fascinating paper. Mark Roth proposed to give hydrogen sulfide inhaled to mice, and what he showed is that after a few hours, oxygen consumption had decreased 85%, CO2 production had decreased 90%, body temperature went to below 15 degrees when they stopped the exposure. So potentially this could be a very interesting avenue to induce hibernation in mammals on demand. And we've all heard about this, that this was a few months ago. Now humans were being placed in a suspended animation. This is the key, the buzzword that the news outlets picked. Could buy surgeons extra time to repair traumatic injuries. Okay, we've all heard of this. Sam Tischerman was actually here 2 years ago. He presented this research on emergency preservation and resuscitation. The video is online. Fascinating stuff. As far as I know, this is news from last week. They have 6 patients, and they're expecting to publish by the end of this year. This is my last point. What if you're dead? What if you're really, really dead? Is there still hope? Well, maybe. At least this is what these companies are trying to sell. You may have heard of these entities trying to offer to freeze you to nearly -200 degrees until the day where potentially we would have the technology to defrost you, without you dying in the successfully defrost you, since you're already dead, and having the cure to the disease that killed you in the first place. So, and on their website, they actually advertise that cryonics is an extension of critical care medicine. Yeah, and I just want to finish with this story, which we're gonna need the microphone again, guys. This is a moving story. Anita is dying. She's got multimetastatic breast cancer. She knows she's dying, and she wants to be frozen. She wants her body to be conserved. So basically, the documentary is about following her during the last days and weeks of her life, and they show the process of her body being prepared for conservation. It is unsettling, but I invite you to have a look.
I have too many tumors to count in my brain. I have too many tumors to count in my lung. I have tumors in my lymph node, in my chest. I have tumors in my leg and my liver. I'm going. I don't know how much longer, but it's there. Very well.
Back at Alcor's laboratory, the intensive process of preserving Anita's body continues.
Can you move the light for him, please?
The hope is that the brain will shrink fairly significantly as a lot of the water is pulled out of the tissue. This helps in the vitrification protocol to
Can you
prevent
hear?
the formation of ice crystals later. We're going to insert temperature probes so we can monitor the temperature of the brain directly.
The Alcor staff claim they're taking special care to monitor Anita's brain.
And we're going to introduce a couple of probes that we call crack phones. These are basically acoustic probes that listen for fracturing events.
But the chemicals and freezing will almost certainly destroy her brain tissue. And with it, everything that made Anita the unique individual her family loved.
It makes me nervous about how my brain will reanimate and come back. And I'm hoping that we come back as a perfect world, that we've learned to give each other common hope and help.
Give each other calm and hope and help. So that's a nice closing message. So just to conclude, our job, everyone's job here is about supporting failing organs, supporting failing organisms when you put the organs together. And sometimes we end up walking a very fine line between what's technically possible, what's effective, what is ethically and culturally acceptable, and of course what's legally allowed. So I do want to thank Armand and Rob McSweeney for the help with the slides. There's some references here, only the best, and my contacts are here if you want. Thank you.
It's some really groundbreaking stuff. Any questions?
And thank you for your patience.
Well, I'm going to hand over to Ollie in a second to tell us about where we're going. But I'd just like to say thank you very much to you and to all of our speakers and to our organisers for putting on a fantastic conference. I absolutely love coming here and I always learn something. It's been really, really good. So thank you.